Good day everyone. For this topic, we will be discussing your myeloproliferative neoplasms. For our learning objectives, it is to be able to distinguish the different types of WBC disorders, whether malignant or non-malignant, and to describe the etiology, epidemiology, clinical signs and symptoms, and laboratory data associated with WBC disorders. So, for our topic outline, we'll be giving you a introduction for leukemia. Actually, it's a recall already since it was also introduced to you in the other topic, which is the lymphoproliferative disorders. And then we'll also be classifying your myeloproliferative neoplasms, the major classification disorders, and the minor classifications. And lastly, we'll also be discussing some of the disorders under the unclassified myeloproliferative neoplasms. Leukemia refers to the cancer of the blood cells. These malignant blood cells proliferate as abnormal and do not respond to normal control or feedback mechanism. In addition, it is believed that these cells produce substances that inhibit the proliferation of the normal cells. And these events usually manifest in the peripheral blood by decrease in the red cells, which is anemia, and the decrease in platelets, which is thrombocytopenia. Now, your WBC disorders are again divided into two: the qualitative malignant disorders. So again, this is the chart that shows your different WBC disorders classification. It is divided based on the qualitative or morphologic abnormalities or changes and in terms of its quantitative amounts. These quantitative WBC disorders are divided into two, whether it can be classified as non-malignant or malignant disorders. These non-malignant disorders were already discussed to you, and now we'll focus on your malignant WBC disorders. We have already discussed your lymphoproliferative disorders, and which are classified into four. So now we'll be focusing now on the myeloproliferative neoplasms. Your myeloproliferative neoplasms is divided into two based on the WHO or the World Health Organization. We have your major myeloproliferative neoplasms and your minor myeloproliferative neoplasms. We will be discussing some of the disorders under these classifications, and then the rest are for your readings. So, your myeloproliferative neoplasms are characterized by disorderly, purposeless proliferation of your WBCs with an overabundance of one cell type. Either it could be a mature or immature WBCs. Now, the term neoplasm refers to an abnormal increased growth of tissue either in the bone marrow and peripheral blood. Now, these types of neoplasms are classified using your cytochemical staining, diagnosis, and clinical findings. Again, just to differentiate your normal WBCs and with your leukemia cells, with the normal blood cells, these are again formed in the bone marrow, and your blasts should only stay in your bone marrow. Hindi dapat sila nare-release sa circulation. Ang nasa circulation lang dapat natin ay yung mga mature cells. But in your leukemia cells, usually your body produces a abnormal WBC, and so your blasts, which usually stays in your bone marrow, are released into the circulation. And these blasts are not yet mature, thus they do not function well. And this leads to an uncontrolled proliferation of your cells. And again, as a recall, these are your differences between your acute leukemia and your chronic leukemia. Again, when we say acute leukemia, the disease gets worse quickly, rapid siya, and therefore it's usually from weeks to months only. And the affected cells are your immature cells or blasts. We have already discussed your ALL, si acute lymphoblastic leukemia, and then in this topic, we'll be focusing your AML naman, or your acute myeloid leukemia. Now, for the chronic leukemia from the name itself, chronic. So the disease gets worse gradually, or there is a slow progression of the disorder, and usually takes months to years for you to be able to know the prognosis and the recovery. And the affected cells in chronic leukemia are your mature cells. And then eventually, as the disease progresses, nagkakaroon na din yung immature cells na affected. Okay? In this topic, we'll be focusing on your chronic myeloid leukemia. So these are the common signs and symptoms and clinical findings seen in all types of leukemia. So take note, since the term is common, so we cannot really determine what type of leukemia we have based on the symptoms and clinical findings alone. Okay? Usually, as the leukemia progresses, it leads to the affected other cell lineages that leads to anemia and also thrombocytopenia. So for us to be able to distinguish and differentiate these neoplasms, we may use your cell morphology evaluation through your peripheral blood and your bone marrow smears, your cytochemical staining, your immunophenotyping, and your genetic studies. So without further ado, I think we can already start with your myeloproliferative neoplasms under your major myeloproliferative neoplasms, which is your chronic myeloid leukemia. Chronic myelogenous leukemia or chronic myeloid leukemia, or simply CML, is a chronic myeloproliferative neoplasm characterized by leukocytosis or increased WBC with an increase in mature and immature cells of your granulocytic series. Pero usually, since it's chronic, ang unang affected na cell ay yung mature granulocytes natin. Thus, it was first described as your CGL or your chronic granulocytic leukemia. Now, this proliferation of mature cells is due to a chromosomal abnormality known as your Philadelphia chromosome or your PH chromosome. In CML, there is a translocation of your arms of chromosome 9 and 22, forming the said chromosome. Now, this chromosome forms a mutated gene known as your BCR ABL1 gene. Kasi yun yung mga genes na nagkabaligtad. Okay? Now, this BCR-ABL1 gene stands for breakpoint cluster region protein Abelson 1 gene. Now, this gene causes the malignant proliferation of your cells. Onset typically occurs 20 to 60 years old of age, with a peak incidence between 40 and 60 years old. Now, this age group accounts for approximately 20% of all leukemia cases, and patients are usually Philadelphia chromosome positive, so you can write it as PH positive, or in other references, pwede din PH1 positive. Okay? And then, in rare cases, these CML may also occur in infants and children under 2 years old, and that is known as your juvenile CML. Juvenile means children, bata. Okay? Now, the difference with your juvenile CML is that these cases are usually Philadelphia chromosome negative. Okay? Philadelphia chromosome negative, or pwedeng PH1 negative. Now, as mentioned, majority of the affected cells are the mature cells. The hallmark of the initial phase of CML is the excessive increase in the mature myeloid cells in the peripheral blood. Okay? Now, your red cell count decreases as the disease progresses. Therefore, as the disease gets severe, there will be the presence of anemia, and usually presents a RBC picture of normocytic, normochromic, with RBC anomalies or poikilocytes of teardrop cells. Your platelets are either normal or increased, And the bone marrow picture shows hypercellular, kasi nga mataas si WBCs, with the presence of myelocyte and metamyelocytes. Again, your CML is PH1 positive or Philadelphia chromosome positive, and in cytochemical staining, lab score is usually decreased, and the myeloid erythroid ratio is 25:1, which is increased. Now, as a recall with your cytochemical staining, your leukocyte alkaline phosphatase or your LAP is used to differentiate your leukemioid reaction from your CML. Again, your LAP is an enzyme found in the secondary granules of your neutrophils. And therefore, since your LAP stains your secondary granules, your stain usually is present in your latter stages of your WBC, which are your metamyelocyte, your band cells, and your segmenters. Fixative for LAP is your citrated buffered acetone and its reagents naphthol ASMX phosphate and fast blue RR, combining them forming a blue colored compound or stain in your reaction. A normal or increased score or a positive lab reaction or score indicates for leukemioid reaction, polycythemia vera, or myelofibrosis. While a negative LAP reaction or decreased scores indicates for CML. Next, we have your polycythemia vera, which is an acquired myeloproliferative disorder characterized by pan-myelosis, or the overproduction of all blood cell lines. It was so called as such because, again, if you're going to decode polycythemia, poly means many, cyte is cell, emia in the blood. So, all cells in the blood are affected. Kaya siya polycythemia vera. It's vera because it's true na increase yung production ng cells natin. Okay? Now, this is primarily due to a JAK2 gene mutation. Your JAK2 stands for Janus kinase 2. Specifically, a valine to phenylalanine substitution at the 617 position on chromosome 9. Okay, so kapag isusulat niyo yung gene mutation affected, pwede naman na JAK2 lang. Okay, pero the V617F just indicates where the substitution or the mutation present in the said disease. Okay, now this mutation is present in approximately 90 to 95% of polycythemia vera cases, leading to a constitutive activation of your JAK STAT pathway and the uncontrolled proliferation of your hematopoietic stem cells. Now, clinically, peripheral blood findings often show your plethora, which is a term that refers to the visible fullness or the redness of the skin due to the increased number of your circulating cells. Now, these increased cell mass results in the hyperviscosity of the blood, which increases your splenic overload or workload kasi ang daming cells na turn over because of the proliferation, which now leads to your splenomegaly and hypervolemia. Now, common symptoms may also include headache, dizziness, paresthesia, and dyspnea, while more serious complication may be involved in your thrombosis and bleeding due to the altered hemodynamics and your platelet dysfunction. Now, we have different types of polycythemias, and what we are discussing, your polycythemia vera, is under your primary polycythemia. We have other types such as your secondary polycythemia or erythrocytosis, which means from the name itself, secondary. So there's another disorder or condition that causes your increased levels of your red cells. And these are usually associated with conditions in high altitude, smokers, patients with hemoglobin variants, with kidney tumors, with high levels of male hormones, and patients with or diagnosed with congenital heart disease. Okay, we have the third one, which is your relative erythrocytosis. From the name itself, relative. That's why it's also known as your pseudo polycythemia. So pseudo means fake. So it would just look like na meron siyang increased number of red cells. Okay, these in this type, conditions such as your dehydration, hypovolemia, burns, and stress are associated with it. Kasi nga, in those cases, there is increased red cells because of reduced plasma levels without the increase of red cell indices. So, nagmumukhang mataas si red cells natin kasi mababa yung plasma volume natin. Okay? Now, you also have to consider the diagnostic criteria for you to diagnose your polycythemia vera as given by the World Health Organization. Patients to be diagnosed with PV should meet your major criteria and some of the minor criteria. Now, laboratory findings in polycythemia vera shows increased red cell count with increased H&H and normal blood indices. In the early stages, there would be normal RBC morphology. However, as the disease progresses, there could be the presence of your teardrop cells, elliptocytes, and your nucleated RBCs. Of course, your WBC and your platelet count is also increased. And since there would be the presence of panmyelosis or the increase of your cells, there could be increased turnover of these cells and could lead to increased levels of uric acid and thus leading to hyperuricemia and your hyperuricosuria. Bone marrow picture shows hypercellular cells present in the marrow. Now, the treatment for polycythemia vera, the main choice of treatment is usually your therapeutic phlebotomy. This is the removal of whole blood into the patient itself. So, it is similar with how you usually donate blood during blood donation. Okay, ganito pa din siya. However, in cases of polycythemia vera, the goal for therapeutic phlebotomy is to be able to decrease the viscosity of the blood. Kasi nga, di ba, madami yung cells niya. So, para hindi siya mag-clump, hindi magkaroon ng complications, kailangan bawasan yung levels. Kaya nagkakaroon ng phlebotomy. This is usually done multiple times or as needed by the patient. Okay? And then, take note that this blood na nakuha sa patient with polycythemia vera cannot be used to donate blood. Okay? Usually, tinatapon na natin yung nakuha nating dugo from patients with PV kasi it has increased number of cells and hindi yun pa pwedeng ibigay sa ibang patient. Okay? Other treatment for this one is usually chemotherapy through the use of your myelosuppressive drugs such as your hydroxyurea, your chlorambucil, your interferon alpha, and your ruxolitinib. Okay? Other treatment may also be used such as your radiation therapy pero hindi na siya masyadong ginagamit because of the risk for another leukemia. Next, we have your essential thrombocythemia or your primary thrombocythemia. This is characterized by a significant increase in the circulating platelets, usually in excess of 1,000 times 10 raised to 9 per liter. Now, elevated platelet counts may be encountered as reactive phenomenon, a secondary to variety of systemic conditions, or may be representative of the essential thrombocythemia, the primary disorder of the bone marrow itself. Now, here on the right side is the criteria for the diagnosis of essential thrombocytosis or thrombocythemia. As per WHO, the patient would be diagnosed with ET if the patient would be able to meet all the criteria given here. Okay, so aside kay polycythemia vera, si JAK2 kinase is also a mutation present in your essential thrombocythemia. Now, clinical findings in ET shows hemorrhage, thrombosis and splenomegaly because of the increased platelets, which leads to the increased turnover of your cells. Now, platelet count is high for up to 600 to 1,000 times 10 raised to 9 cells per liter. And then there could also be the observance of your abnormal platelet morphology, which shows clusters, large hyperlobulated, dense nuclei with increased variability in size. Now, bone marrow picture shows myelofibrosis with hypercellularity and megakaryocytic hyperplasia and masses of aggregated platelets. There could be increased platelet WBC in ET as the disease progresses and decreased red cell count without erythrocytosis. Now, treatment for ET is usually chemotherapy through the use of your anti-mitotic drugs para mag-stop yung proliferation ng platelets natin. And in other cases, we often give whole body radiation. Next, we have your primary myelofibrosis. Your PM is also known or may also be called as your agnogenic myeloid metaplasia, idiopathic myelofibrosis, or chronic idiopathic myelofibrosis. In other old references, it may also be referred to myelofibrosis with myeloid metaplasia or MMM. Okay. Now, this is a clonal myeloproliferative disorder characterized by fibrosis and granulocytic hyperplasia in the bone marrow and the proliferation of your granulocytes in the spleen and liver. Now, this can be classified as primary or secondary myelofibrosis. Primary myelofibrosis is characterized by the systemic bone marrow fibrosis and the use of your extramedullary hematopoiesis. While your secondary myelofibrosis, from the name itself, secondary, it is caused by infiltrative disorders, including malignancies and infections, or exposure to chemical toxins or radiation. Now, in this case, the blood-marrow barrier is disrupted in the course of your myelofibrosis. So, this affects now your blast cells and committed stem cells. Now, these blast cells and committed stem cells escape into the circulating blood in large numbers, leading now to the myelofibrosis or the scarring in your bone marrow, which affects now the growth and production of your cells. So, this is a rundown of the terms that are associated with primary myelofibrosis. And usually, the most constant feature present in myelofibrosis is the presence of this megakaryocytopoiesis or the overproduction of your defective platelets. This results to premature death and release of your alpha granules such as your PDGF, platelet growth factor, and this leads to the increased fibroblastic growth of your tissues, which now forms your scarring in your bone marrow. Now, several chromosomal abnormalities are overrepresented in patients with myelofibrosis. Now, these alterations involve the long arm of chromosome 1, monosomy and partial deletion of chromosomes 5, 7, 9, 11, and 13, the loss of Y chromosome, and trisomy 8, 9, and 21. Now, patients with myelofibrosis usually exhibit progressive anemia, splenomegaly, and marrow fibrosis. Splenomegaly and some cases of hepatomegaly are caused by the use of your extramedullary hematopoiesis. Now, this results to a mild degree of jaundice, abdominal fullness, dyspepsia, or weight loss. Now, patient may also note easy bruising and bleeding resulting from the thrombocytopenia and abnormal platelet function. Now, about 1/3 of patients manifest purpura. And then more than 40% of patients with primary myelofibrosis exhibit osteosclerosis with accompanying bone pain, malaise, and leukocytosis. Initial lab findings in primary myelofibrosis shows moderate erythropenia with leukocytosis that affects your mature cells and increased number of platelets or thrombocytosis. In the latter stages of the disorder, there would be the hypocellularity of the bone marrow with moderate to marked amounts of reticular fibrosis or collagen deposition. There would be also the use of your extramedullary hematopoiesis, and also in the circulation, there would be the presence of peripheral cytopenia or decreased cells. Now, the pathologic blood film of patients with PM shows occasional nucleated RBCs, giant agranular platelet, a rare megakaryocyte fragment, occasional immature myeloid cells, and rare myeloblast. Now, take note also the diagnosis criteria for primary myelofibrosis. According to the WHO, the diagnosis requires in meeting all the major criteria and 2 out of 4 minor criteria to be able to be diagnosed with primary myelofibrosis. So we're done now with the major myeloproliferative neoplasms. We'll proceed now with the minor myeloproliferative neoplasms, and in this lecture, we're going to discuss only your chronic neutrophilic leukemia. Chronic neutrophilic leukemia, or simply CNL, is the rarest myeloproliferative neoplasm characterized by the hyperproliferation of your neutrophilic cells. Now, 80% of cases are due to the mutations in the cytokine CSF3R gene, which stands for your colony stimulating factor 3 receptor. Okay? Now, this CSF3R receptor is a receptor for your GCSF, or your granulocyte colony stimulating factor. Now, in this mutation, there is the substitution of your threonine to isoleucine in the 618th position of your CSF3R, which leads to the constitutive or constant activation of your receptor, promoting now the uncontrolled proliferation of your neutrophils. Now, to be able to differentiate your CNL with CML, kasi di ba pareho silang affected is yung granulocytic lineages and mature pareho. You have to check now the presence of your Philadelphia chromosome. Now, a negative Philadelphia chromosome is highly associated with CNL. Now, once diagnosed, survival rate of patients range from 6 months to 20 years depending on its progression. Again, sa CNL, Philadelphia negative. Sa CML, Philadelphia positive. Okay? Yung juvenile CML, Philadelphia negative. Okay? Now, karyotypic changes are usually not associated with CNL, but in rare cases, there could be the association with trisomy 8, trisomy 9, and trisomy 21. There could also be deletions on the long arm of chromosome 20, long arm of 11, and long arm of 12. Now, clinical manifestations in CNL shows hepatosplenomegaly with abdominal pain because of, again, the increased turnover of your cells kasi nga madami sila. And since there is increased number of cells, there could also be manifestations of gout and bone pain, pruritus, and mild to severe hemorrhagic episodes. Now, laboratory findings in CNL under its peripheral blood smear shows neutrophilic leukocytosis without a left shift as high as 100 times 10 raised to 9 cells per liter are present in the PBS of patients with CNL. There could be normal or slightly decreased platelet count and mild anemia. And usually, if there would be mild anemia, there would be slightly decreased levels of hemoglobin. WBC anomalies present in CNL are your toxic granulations and your DOLA bodies. These are your DOLA bodies. Ito siya, no? Ito. And then your toxic granulations. Now, in the bone marrow of patients with CNL, it could be described as the presence of hypercellularity with granulocytic hyperplasia, and maturation of granulocytic cell is normal, but there would be increased production of your neutrophils, leading to neutrophilic hyperplasia. There could be no signs of myelodysplasia, and the myeloid erythroid ratio is 20:1 or greater. So, mas malaki yung myeloid. Now, we can also use cytochemical staining in the diagnosis of your CNL. The lab score could be as high as 350 to 400 score, and there will be increased levels of your vitamin B12. So, there's no standard treatment for CNL. However, the usual use of your myelosuppressive drugs, such as your hydroxyurea and interferon alpha, are used to be able to stop the increased production of your neutrophils. And then, we can also perform splenectomy to be able to decrease the complications present in the increased turnover of your cells. And the main treatment that they see as a choice for CNL is the stem cell transplant, kasi yung problem again is yung sa bone marrow. So, we're now done with the major and minor myeloproliferative neoplasms. We'll proceed now with the unclassified NPNs. Actually, hindi lahat to guys under sa unclassified. I just placed them here so as not to confuse them with the major and minor NPNs. Okay? For example, si SHEDJAC at si CGD, pwede din silang maklasify under the qualitative WBC disorders. And then, your AML, in other references, it is classified under the major MPNs. However, according in the WHO, it only classifies CML as a major. Okay, kaya siya nandito. Okay? And then NPD, your Niemann-Pick disease and your Gaucher disease, these are not specifically under MPNs. However, this also affects the maturation of your WBCs, kaya isasama natin sila. Okay? For this lecture, we'll be discussing your AML, your Gaucher disease, your CGD, and your Shijak-Higashi syndrome. First off is your acute myeloid leukemia, or simply AML. This is the most common type of leukemia in adults, and the incidence increases with age. This is characterized by the predominance of your immature marrow cells or your blast cells, and arrest their maturation in the bone marrow and circulation. It may also be referred to as your acute non-lymphocytic leukemia and acute granulocytic leukemia. Now, etiology for said leukemia is unclear, but may be influenced by the following factors: exposure to radiation. Okay, ito yung mga na-expose sa radiation, yung nag-undergo ng radiotherapy, at saka yung mga people that were affected in the Hiroshima and Nagasaki bombing in Japan. Okay, aside from that one, risk factor din yung exposure sa chemicals and other genetic aberrations, and exposure to viruses, specifically your type C viruses. Now, for you to be able to classify AML, it could be based on your FAB classification or your WHO classification. Your FAB stands for French-American-British Association, and it classifies AML subtypes based on the cellular morphology and its cytochemical staining. While for WHO, it classifies your AML based on its cytogenetics and molecular characterization. So, mas modernized si WHO, and usually every 2 years nag-update si WHO. In the medtech profession, ang fina-follow muna natin ay si FAB. Saka nyo na problemahin si WHO classification kapag sakaling maisip nyong mag-medicine. Okay? Now, On the FAB, these are the different subtypes for your FAB classification of your acute myeloid leukemias. We have M0 until M7. Meron tayong M8. Okay, mukha lang siyang M8. Ito yung recall sa boards. This is your acute basophilic leukemia. Pero sobrang rare nito, kaya hindi siya kasama sa subclassification ni FAB. And also, FAB is already a old classification. Hindi pa tayo buhay lahat. Meron ng FAB. Okay, so hindi na siya na-update. Unlike with your WHO. Ito naman si WHO. Okay, in our current edition for Rodax, ang current update niya is 2017. Okay, ito yung mga yon. Pero upon checking in the internet, I think meron na tayong 2022 WHO classification ng AML. Mas nadagdagan yung mga to. Okay, pero for now, you don't have to memorize them. You just have to be familiar na pag ganito yung itsura, ang nag-classify ay si WHO. Okay? Since our focus is with the FAB classification, which uses mainly your cytochemical staining to differentiate your different subtypes, let's recall your two major stains used in AML, which is your myeloperoxidase and your Sudan black B, both of which produces a blue-black precipitate, which indicates a positive reaction. For myeloperoxidase, this is an enzyme that is found in the primary granules and azurophilic granules of your blast cells, and usually stains your agar rods and your leukemic myeloblast. On the other hand, your Sudan black B is a lipophilic dye that binds irreversibly to an undefined granule component present in your granulocytes, eosinophils, and some monocytes. This is mainly used to differentiate your AML with your ALL. Okay, so hindi na-sustain si lymphocytes sa Sudan black B. And it also detects cellular lipids such as your phospholipids and your triglycerides, and could be able to stain your myeloblasts, and again, not lymphoblasts. Kaya siya ginagamit pang differentiate with ALL. Another cytochemical stain that we use to differentiate your AML subtypes and your other lymphoblastic leukemia is your per-iodic acid shift. Ay, ba't wala siyang header? Per-iodic acid shift. Okay, now this is used to oxidize 1,2-glycol groups to be able to produce your dialdehydes. Now these dialdehydes give a red color reaction when exposed to your Schiff's reagent. Now this red color reaction indicates the presence of your mucoproteins, your glycoproteins, and your high molecular weight carbohydrates. That's why diba ginagamit siya sa histopad. Now, in hematology, this is used to differentiate your myeloblastic and monoblastic leukemia from your lymphoblastic leukemia. Now, positive reactions for PAS are usually with your neutrophils except the blast, your subtype M6 for your AML, and then it varies with your eosinophils, basophils, monocytes, lymphocytes, and your leukemic lymphoblasts. It usually stains negative with your red cells, myeloblast, and your monoblast. And then lastly, one of the cytochemical stains that we also use for in differentiating your AML is your non-specific esterase and your specific esterases. Just a recall, remember the substrates that is used for non-specific and specific esterase, the positive and the negative reactions associated with the use of this cytochemical stain. Now, these are the different subtypes according to your FAB classification of your acute myeloid leukemia. So, I made a summary on the predominant cells that are affected in each of the subtypes and the cytochemical results associated with them. Kindly please remember them, guys, ha? Okay, hindi na natin sila isa-isahin kasi I think you could be able to study them on your own. Just remember the names of each subtypes. Okay? Yung predominant cell, usually naka-bold naman sila. And yung mga cytochemical results nila. Okay? Yun lang yung mga tatandaan nyo dito. Although madami, yes. Pero yun. Yun lang talaga. Yun lang ang only way to remember these. Okay? These are M1 to M4. And then you also have your M5 to M6. Just remember guys that yung pinaka-common na laging tinatanong sa board exam ay si si M3. Okay? Which among the AML subtypes is associated with the IC? Ang sagot, si APL. Okay? Tapos, sino din yung associated kay our rods? Siya din, si APL. Okay? And then, yung fagot cell, which is the bundles of our rods, associated din siya kay APL. Okay? Ayan. And then the other names of your other subtypes, such as your M5. Your M5 is also known as your Schilling's leukemia. And then si M6 siya si de Guglielmo's syndrome. Okay, tatandaan yung mga yan. Okay. Now, treatment for AML. The main choice of treatment is your chemotherapy with the use of your cytotoxic agents. Usually, these are your cytosine, arabinoside, which is a myosuppressive agent. We also have your daunorubicin, which is also a myosuppressive agent, and also your amsacrin. Amsacrin pala, sorry guys. Amsacrin. Okay? This is also a myosuppressive agent used as a chemotherapeutic drug for the treatment of AML. Okay? And then other treatment that may also be used aside from chemotherapy are your immunotherapy, radiotherapy, and your bone marrow transplantation or stem cell transplantation. Next, we have your Gaucher's disease. Your Gaucher's disease is the most common of the lysosomal lipid storage diseases, and its inheritance pattern is autosomal recessive. Now, this is caused by a defect or deficiency in the catabolic enzyme beta-glucocerebrosidase, which is important in the glycolipid metabolism. Now, the gene that is associated with this one is at chromosome 1. Now, there are 3 clinical subtypes of your Gaucher disease. You have your type 1, non-neuropathic, type 2, acute neuropathic, and type 3, subacute neuronopathic. Kindly please take note the age presentation for each of the clinical subtypes. So, usually naman sa childhood or adulthood. And then, which among them is affected with the central nervous system. Usually, si type 1, from the name itself, non-neuronopathic. So, hindi affected si CNS. And then, for types 2 and 3 are affected. Okay? And then, in type 1 of the Gaucher disease, this is the most common type and usually affects your Ashkenazi Jews. Now, clinical findings for Gaucher disease shows anemia and thrombocytopenia, and the hallmark present in your Gaucher disease is, of course, from the name itself, si Gaucher cells. So, hindi na kayo magkakamali. Okay? Basta Gaucher disease, Gaucher cells. When we talk about Gaucher cells, these are distinctive macrophages, single or in clusters, that exhibits abundant fibrillar blue-gray cytoplasm with a striated or wrinkled appearance. That's why sometimes these macrophages are described as onion skin-like. Nakakita na kayo ng onion skin. Yan, yung mga pag-ganon-ganon. Okay? Or crumpled paper appearance. Okay? These usually stain positive with trichome, aldehyde fuchsin, periodic acid shift, and acid phosphatase. Now, treatment for Gaucher disease includes enzyme replacement therapy with recombinant glucocerebrosidase and substrate reduction therapy, or SRT, wherein agents that are able to reduce your glucocerebrosidase enzyme production. Okay? Now, allogeneic stem cell transplantation may offer a potential treatment for Gaucher disease. However, mortality rate is high and it needs further studies to determine the standard of care for this treatment. Next is your CGD, or chronic granulomatous disease. Other names for this disorder may be known as your chronic granulomatous leukemia, Bridges-Good syndrome, and your Kia syndrome. This is a group of genetic disorders wherein your neutrophils and your monocytes ingest but cannot kill your catalase-positive microorganisms. These are your SNPs. Naalala si SNPs? SNPs is your Staphylococcus, Nocardia, Aspergillus, Pseudomonas or Burkholderia, si E. coli. Okay, you can also add your Candida and your Listeria as organisms that are catalase positive. Okay, in CGD, it is a rare inherited disorder caused by the decreased ability of your phagocytes to produce your superoxide and reactive oxygen species such as your H2O2 or your hydrogen peroxide and your hypochlorite. This leads to a absence of your respiratory burst after phagocytosis of your microorganism. Kaya hindi natin na fight off yung mga infections na to. Okay? Now, most CGD cases are X-linked recessive. Okay? 60 to 65% are X-linked recessive. And then the rest, 35 to 40% are associated with autosomal recessive inheritance pattern. So kindly please take note the different genes that are involved in CGD. Okay? This is the pattern of inheritance. This is X-linked recessive. Thus the rest are autosomal recessive. Take note the gene associated with it and the protein product associated with it. So CYBB is affects your protein GP91-FOX, and that leads to mutations in your chromosome itself. Same as with the others, CP22-FOX, P47-FOX, P67, and P40-FOX. Okay. Now, recurrent bouts of infection due to decreased capacity of immune system to fight off disease-causing organisms in CGD leads to the bacterial and fungal infections of the lung, skin, lymph nodes, and liver. This now leads to the formation of your macrophage-rich granulomas, which is usually found in the liver, spleen, and other organs that are affected. When you say granuloma, this is a lymphocyte. Okay, lymphocyte aggregates on the neutrophil with the presence of the live bacteria kasi nandun lang sila, na-ingest sila, pero hindi sila na-kill. Okay, now this usually manifests as a purpuric lesion or red lesions in patients with CGD, and then in their tissue, under the microscope, ganito yung itsura niya. Okay, now, laboratory test that we can perform to diagnose CGD is the use of the screening test, which is known as your nitroblue tetrazolium test. This is a cytochemical stain also, and a widely known screening test for CGD. Its principle is the use of the enzyme is to test the enzyme activity of your neutrophils. A normal neutrophils usually presents a blue color compound reaction, okay, while in patients with CGD there would be no change in the NBT color. So a absence of the color blue compound in the neutrophils indicates for the presence of CGD. Confirmatory tests that we can perform for CGD are your flow cytometry tests with the use of your fluorescent probe dihydrorhodamine 123. Also, your gram staining and your acid-fast staining to be able to examine your acid-fast bacilli and your fungi present in the granulomatous disease. And also, serological tests with the presence of IgG, IgM, and increased IgA levels. Last disorder for this topic is your Shijak-Higashi syndrome. Its inheritance pattern is autosomal recessive and is associated with a mutation in your CHS1 LYST or your lysosomal trafficking gene on chromosome 1 that encodes for a protein that regulates the morphology and function of your lysosome-related organelles, or LROs. This is characterized by the presence of a partial oculocutaneous albinism, frequent pyogenic bacterial infections, giant lysosomal granules in cells, platelet-dense granules deficiency, and hemorrhage. Now, laboratory findings in Shijak-Higashi syndrome shows presence of enlarged lysosomal vesicles, mainly in the monocytes and sometimes in your lymphocytes. These are known as your Shijak-Higashi granules. These are giant granules or giant lysosomal granules present in your neutrophils, monocytes, lymphocytes, and melanocytes. That's why there would be the clinical manifestation of your partial albinism kasi affected din si melanocytes, which has your LROs. Okay? Again, the characteristic feature present in your Shijak-Higashi syndrome is your Shijak-Higashi granules. Take note, guys, that there is a so-called as your pseudo Shijak-Higashi granules, and these are cytoplasmic inclusions that resemble your Shijak-Higashi granules. Okay? These are reported in patients with your acute myeloid leukemia, your chronic myeloid leukemia, and your myelodysplastic syndromes. So I guess that ends our discussion for the myeloproliferative neoplasms. I highly suggest that you further read your books also for additional information aside from the discussion itself. Thank you for listening.